All right, it's 12 o'clock, so we'll go ahead and get started. Welcome to Medical Grant Rounds. As always, thanks for folks being here on a slightly snowy Wednesday. We will continue to hold Grant Rounds in person throughout the year here in the Krugman Conference Room, and of course, keep things going on Zoom for folks to watch if they can't make it. As a little bit of a teaser, next week is not in person, so do not come to this conference room tomorrow. It's our Systems Improvement Conference led by Dr. Anstedt, Vera Ponce, and their team, and so that will be only virtual. And then the following week, we're going to welcome Dr. Katrina Armstrong, who is the CEO and the Dean of Columbia University. And she's going to talk to us about breast cancer screening and prevention and leadership in that space. As always, CME and MOC credit are available for all Grand Rounds. Please also use this link to nominate speakers for next year's medical Grand Rounds. We are all in academic medicine, and you will note that the deadline is today. So that means most nominations will come in tonight, and that is fine. So let us know who you would like to see here next year. Now, it really is my pleasure to introduce Dr. Doug Corley. Dr. Corley is a clinical professor of medicine at the University of California, San Francisco, a member of the UCSF NCI Comprehensive Cancer Center, and a senior research scientist at the Division of Research at Kaiser Permanente of Northern California. He did his undergraduate work at Berkeley, where he graduated with distinction. He was a medical student at Penn. He then did his internship and residency at Brigham and Women's Hospital, associated with the Harvard Medical School, and was a fellow in GI at UCSF. He also got advanced training. He got an MPH in epidemiology at Berkeley, where he also received his PhD several years later with a focus on cancer epidemiology, genetic epidemiology, and biostatistics. Dr. Corley is a true clinician scientist with an expertise in building collaborative, transdisciplinary, diverse teams and developing large clinical and translational research programs. His research, which has been funded by a series of 46 awards over the years for he and his teams, includes fundamental risk factor epidemiology and emerging diseases, broad-based disease pathway discovery and genetic and metabolic epidemiology, and then complex pharmacoepidemiology, including work with the U.S. Food and Drug Administration and other collaborations. His current research emphasizes developing collaborations between clinicians and translational researchers through epidemiology, translational sciences, and then implementation specialties, and to advance large clinical change across large healthcare systems. Nationally, he is the co-editor-in-chief of the journal Gastroenterology. He has been the National Steering Committee chair for the 10-center NCI population-based research optimizing screening through personalized regimens, or the PROSPER Consortium. And he is the project director for the multi-site PROSPER colorectal and cervical cancer research screening criteria centers. He has substantial experience fostering successful, diverse teams with multi-specialty collaborations and creating structures where clinicians and researchers can develop and integrate new techniques and work more closely together. And I will just end by saying, in addition to his research, Dr. Corley is a dedicated clinician. He has been providing expert care to patients with a wide range of GI conditions for a number of years. He really is known for his compassionate and thoughtful care, his approach to patients, and his ability to communicate complex medical topics, not only in the research space, but in the clinical space. So it really is a pleasure today to welcome Dr. Douglas Corley.
Thank you so much. Can you hear me okay? Is this okay? I apologize if any of you were thinking that this was going to be a talk around colorectal cancer. I did give a talk on colorectal cancer to the GI division on Monday, and there was a transposition that was also going to be today. I'd love to talk about it. It's a big area of interest for ours. But the main topic, which is a little bit broader, that we had talked about with your chief, was in terms of was actually how to be able to kind of like accelerate change and kind of career opportunities for that, developing funding mechanisms for that, et cetera. And he cleverly made the GI pun that maybe that actually would be a better fit. But so I'm going to start off talking about a little bit of the background. In 2019, a conference came together that included PCORI, the CDC, the VA, the NCI, the NIH, private insurers, and a number of actually large public health systems gathered together in Pasadena. And really to discuss like what was thought to be potentially kind of like the next frontier in terms of research and development, which is something which is called embedded research. How many people are familiar with this topic or are familiar? I'm also going to walk around and I'm also going to talk and ask questions, and this is going to be kind of somewhat interactive. So how many people have heard of this term before or would consider yourself an embedded researcher? If you haven't heard of it, then I wouldn't consider yourself an embedded researcher, but if you're familiar with the term. Okay, great. So this is going to be relatively new. One of the main quotes that kind of came out of that was, it's not a matter of how we can afford to build infrastructure for embedded rapid cycle chains, but it's how can we afford not to. And this really goes across all of these groups, both the people who are the researchers, as well as the people who are the leaders of all of these different organizations. This is Jim Kim. He was actually the former president of Dartmouth and the president of the World Bank. He was someone who I also was a really fun co-resident with me. And in between being resident in that, he also led the World Health Organization's tuberculosis eradication program. Not the usual career path, becoming the president of the World Bank. But he did have this unique observation back in 2010, was he was really trying to be able to say, how can globally we change care? How can globally we improve health? And he said, really, we cannot address the ever increasing and unsustainable costs of healthcare without getting to the foundation of how care is provided. Nor can we provide or achieve the social and moral goals that we share, care that is safe, appropriate, effective, and high quality for every patient in every community without rethinking and redesigning delivery. Real improvements require a multidisciplinary approach. I would kind of add to this, not just the concept of delivery science, but really like a pragmatic research, applied research, kind of like around some of the ifs and hows. And we'll kind of talk a little bit about that too. And then this is kind of followed up in David Atkins. This kind of gets a little bit more to the embedded research concept. But that, the leaders of healthcare organizations and health service researchers too often occupy different worlds, with different cultures, different economies. And I think this is interesting from the standpoint of anyone who's a researcher, different senses of time. They're united by the need to solve a persistent problem. There isn't enough good research to answer health systems' most pressing problems. And as a consequence, much of our investment in research is wasted developing solutions that don't improve care because they're never implemented. And I would kind of tag this on that, like when you spend 2 or 3 years or more on a research area that actually never results in any change, that's something, that personally has changed some of my trajectory, kind of over time from the types of questions that where our group aims to answer. So, this concept is really rapidly developing. I think part of it came from Leora Hortz in NYU. They had published a sounding board in the New England Journal in 2019 that was talking about essentially rapid cycle randomized testing, which is actually kind of like a form of embedded research. And they described the program they put together. There actually was a whole effort to issue within the National Health Service in England. This was just published really around about how to be able to make the concept of embedded research run smoothly. And it's really quite international. There's a whole issue that was just dedicated to this within healthcare systems. And also, it's not just about healthcare systems, but it's really about us as researchers, on how this can kind of create additional and different careers. So, gosh, what the heck does this actually even mean? I think it probably means different things to different people. But I thought this definition, somewhat of a definition from the National Health Service in England, actually kind of provided an interesting perspective. It's really about knowledge co-production. Knowledge co-production. So the researcher is co-producing knowledge with clinical leaders who are within the healthcare system, and that researcher themselves are embedded within the healthcare setting, because it's embedded researchers carry out researchers in partnership with the healthcare teams who are then able to rapidly use their findings. So that's more or less what an embedded researcher or embedded research is. What are kind of like the differences? So I think a lot of people, even who are in this field now, are kind of doing both. We have a lot of NIH and NCI funded research, but we also are doing research which kind of falls into this other realm. And so, with that in mind, what is like the traditional health outcomes or clinical researcher? I would kind of conceive of it almost as an individual business. You're kind of like an individual proprietor. How many people have been to San Francisco? Has anyone been to the Ferry Building, which is downtown? Yeah, so the Ferry Building is just like where all the ferries used to come in. And but it's basically been turned into kind of like a giant kind of farmer's market. And like inside, there's all these little individual stalls. And I think of research, or even most research institutions, such as the University of Colorado or ours at Kaiser Permanente, as really being the Ferry Building. You provide a structure, there's somebody who comes through and cleans things up, they make sure the roof gets fixed, they provide electricity, and then what happens in each of the stalls? Well, in each of the stalls, that's where kind of like this person comes in. You set up your own business. You go out and you get grants. You hire people. You conduct the work that actually needs to be done, and you pay kind of like a tax on that that kind of helps to be able to keep the ferry building going, but really you are your own business. The person often relies on fairly complex external funding, usually from like a bunch of different sources, and tends to have long time horizons, which are largely driven by these sources. I'm going to give a couple of examples and we'll kind of circle back to this. And I just would like you to, I'm going to ask you to imagine, like, for that project, what you think that would have looked like if you had to put in a federal grant. So what does the embedded researcher look like? They really tend to be much more part of a team. So they're not like a single person. They are really a collection that are working together to be able to figure out, what are the questions? How would we move this forward? How would we look at it? It's usually some combination of internal and external funding, because most researchers are not necessarily going to be fully funded internally by this. And the last thing is, it tends to be like, really, it's kind of on the clock. It's rapid cycle. And that's because part of this internal funding is coming from the healthcare system that you're within. And that's where that interesting quote at the beginning about different time horizons. If you are the CEO of the healthcare system, or the CEO of the medical group, or any really person who's kind of like clinically and operationally a leader, you're usually not interested in something about, can you answer this question for me in 6 years? It's usually like, I've got a question, we're thinking about starting this new program a half a dozen months down the road. Can we answer this before we do that? Or some variant along that. Oftentimes that discussion is like, let's slow that down a little bit. If you want to know, but this is in general what the differences are between the two. So, okay, we're going to stop a second here because this is going to get a little bit more personal. I'd like to be able to get at least a moderate diversity. So, like, why did people here go into medicine? Some people, that's going to be a fairly recent decision. In other words, it's going to be like, let me think about that. I think this was the 18-second rule, where 18 seconds cannot pass without someone interrupting the silence because it's too uncomfortable. So, oh, come on. This is an easy question. Anyone raise their hand?
I'll say it. I felt like I wanted a platform to do big change.
Okay, a platform to be able to do big change. Because interested in actually being able to help individual people and make an impact on their lives. How about a few others? Mm-hmm. Okay, so inpatient, I'll repeat, just also, I imagine some people are online. So within inpatient care, but also doing research and essentially trying to be able to help both individual people, but also do things that will impact care kind of like more broadly. Others? To be able to extend care to different populations, especially populations which have not traditionally been as an amount of benefit versus the extraordinary amount of dollars that we spend in the United States. Others? So not just like what we're doing right now, like what do we do in medical school? We like learn, this is what we're doing and this is what you're going to do. But actually to be able to improve future care on the individual level or on the broader level, or? Yeah, both. Yeah, so I mean, kind of like what you do, but maybe also what other people did. So, every one of these things is like an embedded research type question. Improving patient outcomes, being able to improve healthcare value or efficiency, enhancing individual patient experiences. You could also say provider experiences. Some people go into it because they love the educational and training mission. And this is just kind of like a different way of being able to manifest that. The whole program development part, which was mentioned. Some people go into it because they actually are interested in being able to have from the physician component, like, wow, physician burnout. This is like a real big problem, or physician, like what the physicians do actually on a daily basis. And then sometimes people go into it also, although no one had mentioned this, but sometimes people are interested more like in the corporate side, of how to be able to actually run kind of like the healthcare business. And so on some ways, research or innovation can help to evaluate signature programs from membership or brand. But a lot of this, where you sit, that kind of depends upon where you stand. But there are ways that all of these things can kind of like happen. Sorry, that like went through twice. So I think the other concept is just that as physicians, we usually are doing two things. There's single interactions have a huge impact on us and our patients as individuals. It's hard not to remember the patient I saw 2 weeks ago who was 46 years old a year before that, when I did a screening colonoscopy on him, and he had an early stage cancer, and he had 2 small children, and he's alive now because of that. And that day, actually, I had 2 patients who are both like 40, 46, 47, who both of them had like moderate sized cancers, and both of them, it just happened to be, because that's a very personal thing when that person comes back. But then there's the meta level changes. Like that one colonoscopy may have done something for that one person's health and welfare and their families, but then there's the changes that you make that might be affecting large populations, including underserved populations that have never had care before or have had inadequate care, or that for disorders that are not being kind of like optimally managed. So one of the things that is really intriguing about embedded research is it kind of operates on both of these. As you were saying, and I apologize, I don't know your name, but like, the improvement of the single level interactions of like what you're doing, and then also on the meta level changes. So I'm from Kaiser Permanente, Northern California. One of the things I've appreciated in talking to people is that a lot of people kind of like don't know what that really kind of like means, or kind of like what that necessarily is. Kaiser Permanente, each of the regions is kind of a freestanding region. Our region takes care of 1% of the population of the United States. It's about 4.5 million people. I also do collaborations with Southern California, where collectively we take care of about 1 out of every 30 people in the United States. So it's a big population base. These are just like the medical centers that we have. And our division of research is in Oakland. KP has a long-standing, a lot of people say, Kaiser does research? It's kind of like saying Blue Cross does research. I never kind of heard of that. It's mostly NIH, NCI funded. It's about 60 full-time investigators, about 600 full-time staff in terms of project managers, biostatisticians, et cetera, et cetera. It's been around in various iterations from the beginning, when they were doing the first dose ranging trials of penicillin for like, what dose do you need for pneumococcal pneumonia, in the 1940s. And through, and then in the 1960s, the first NIH grants around developing an electronic medical record using Fortran cards, if anyone actually knows what those are. And actually in the Smithsonian Institute is a box of the Fortran cards from that first electronic medical record, that was developed through that. So this is, I'm going to be talking, this is just the setting of what I'm going to be talking about to provide a little bit of kind of like a background. And the main thing has been, the thought was, and I'm sure that some people who are in dissemination or implementation research, this thing like, improvements are taking too long. This is one of my favorite titles of all time. The answer is 17 years. What is the question? Understanding timelines and translational research. And the concept around this was just that from start to finish, when something was started to when it actually was finished, and then from when it was finished to kind of like when it was in broad implementation, that kind of took like around 17 years, really. So the first part is like, what do you even consider start? Is start like when there's a trial registration or there's a clinical trial published? What do you consider to end? Like when it's introduced into a guideline or a publication, there's FDA approval. I would say most people probably think it's actually even further out here, when it's actually not just a guideline, but hey, people are actually doing this kind of broadly in clinical care. So, where is this kind of evidence-based innovation needed? I would just say as clinicians, you have questions every day. One question that, we were talking about, which was one of the things which I talked about on Monday, but won't be talking about today, was like, as a gastroenterologist, about a third of your patients have like 1 or 2 small precancerous polyps. They're called adenomas. And the guidelines said, oh, well, it used to be actually that person, when I was a fellow, that person was recommended to get a repeat colonoscopy in 1 year. And then it changed to like 3 years. And then it changed to like the most recent guidelines, not fairly recently, were like 5 to 10 years. So when we started looking at this, it was like, oh, well, someone should have a repeat colonoscopy in 5 to 10 years. that seems like a big time range, especially like over a lifetime, it's like twice as many colonoscopies. So that was kind of like one of those niggling questions that you're like, this makes no sense. Can't we have a little bit more certainty around this? That kind of drove a lot of research. The answer is it's probably 10 years, and if you take it out, the risk is about the same as if you'd had a normal colonoscopy. Although we're actually involved in a large national trial around this currently. But really just kind of, we have all sorts of questions. And so we've kind of reframed this. And this is kind of like everything that we do now is like more or less like, if we know X, then we will do Y. That is like actually an interesting question. If you know something, then you have kind of some action. There can be other things around this, like does X work at all? Should we be doing X or Y? Should we just stop doing X? Or is there a lot of variation around X? Like, why do some people do this and some people do that? Does that actually kind of really make sense? And so being able to frame it this way has kind of like helped to be able to sharpen like some of the thinking. But one of the challenges is that really that's just kind of research. But if you want to be able to do evaluation and implementation, there are just so many groups that need to collaborate. There's like chiefs groups, there's like the clinicians, there's traditional researchers or analytics. There's often healthcare system people. They may be in charge of the financial part, or they may be in charge of the IT. There's medical center leaders. There's medical group. And if you want to be able to implement something, it can be really tough. How many people have kind of like had an idea and then they kind of like wanted to be able to change like care in their department, or they want to be able to change the hospital? Yeah. Can anyone, would you mind sharing kind of like what that idea was? Yeah, so like wanting to be able to set up a multidisciplinary clinic. So you can imagine the patient would be like, wow, that would be great. The docs might be like, wow, that would be great to kind of like set up somewhat of a community around this. And then you kind of start running into some of these other things like, well, I don't know, is that going to like, that sounds like that's going to be taking people out of patient care just to like talk. What is the financial, researchers probably not involved with that, but, medical group leadership and other people, it's like, well, I don't know, how are you guys getting it together? Are we going to have to provide some support for that? Is this going to be reimbursed? So there's all sorts of things like that are different initiatives that seem like they might make a lot of sense, may or may not actually move forward. So, and it's often unclear like where to go, like what to do or how to best to disseminate results. And so what I'm going to talk about today is largely, I want to actually be able to learn from you a little bit more what's being done within your healthcare system and the university around these topic areas. And I'm going to talk a little bit about the one model of a system that we've worked on over the last 4 or 5 years that we also think may be adoptable to different centers because it really aligns incentives across all of these groups and allows both funding and projects kind of like to be able to move forward. So from your experiences, either from some of the folks who raised their hands or anyone else, could you just, it would be great to hear kind of like a couple of other examples of like some change that you wanted to be able to make, or even just like what you think the reasons for this kind of like, oh, we have an answer and now we're not kind of like implementing it. Like what are some of the barriers that you've run into here, or that just even kind of theoretically? You would?
Sure, yeah, I think funding. So who's going to pay for the thing that you want to implement if it costs something above the current price?
And so this is so the answer was like funding for kind of like the implementation part, especially if it's not, like making money for the organization or you're not able to make some money. So I guess one question I would have is, so would that be for something that kind of the knowledge base is already there? Like we know this is a good idea, or is it for something that you would actually even need to explore, like to kind of create an evidence base to know whether this was a good idea before you did it?
I would think both. Often both of those things cost either money or time or resources. So I think they require support along that line.
Great. Other things? There were a couple of other hands of people who had, yeah.
Yeah, one thing I talked about earlier today was, in GI, screening colonoscopies, big focus of what we do, and the ability to, we know that we've known for years, that the proportion of patients in which we detect an abnormal adenoid infection that is a big predictor of future interval cancer. Yet it's a process, a quality metric that there is a lack of investment in terms of not only tracking it, but actually looking to actually do an intervention to improve it. So.
Yeah, so a great example for those of you who may not have heard it, it was around basically around quality interventions. And oftentimes quality interventions may improve outcomes, but there's not really like a reimbursement system kind of for that. And the example was from colonoscopy quality. If you're not familiar with it, kind of like having a post-colonoscopy cancer is associated with the likelihood of what's called adenoma detection. So if like a doc, the gastroenterologist, does 100 procedures, and in 30% of those, they detect at least one precancerous polyp, that doctor would have a 30% adenoma detection rate. It's known that this is varied from 10% to 60% between doctors. And it's associated with your risk of post-colonoscopy colorectal cancer. So within our system, this is actually one of the, we were talking about this because this is one of the things that we were both interested in and we've done research on before too. We've developed an intervention, kind of a feedback other than intervention, that has actually decreased the number of post-colonoscopy cancers by about 50% over the last 7 years. But it's really hard to be able to do this because like no one pays for that. And if anything, the incentive, this sounds horrible, but the incentives are actually the opposite. Because if you're doing it, you might be like slowing down the gastroenterologist a little bit, and they're getting paid to be like do more exams, even though it only adds like a minute or two to the exam. And theoretically, from a system standpoint, no one is getting reimbursed for that, but people are being reimbursed for taking care of the cancers. So the prevention aspects and the quality aspects, can be like very complex. Any others?
Technical data, great policy, almost zero. We're approaching 7% of individuals trying to reach the function that have actually barriers, challenges from individual parameters, all of that.
Could you clarify a little bit more what your thoughts are on the individual parameters part?
Oh yeah, it's individually experienced bias and stigma, but it's just the nihilism that the community feels around lung cancer. And why would you do this reading something you perceive that you're going to die horribly quickly? Would it be better not to know? So until we deal with that individual level characteristic of how nihilistic someone is about the possibility of what we know in medicine, great care for lung cancer, or I think rapidly improving care for lung cancer with a lot more options, then it just makes no sense.
So this is actually really interesting because this was something that's been randomized trials around for lung cancer screening and benefit. Theoretically, you would think a lot of these things are aligned. There probably would be a fear of lung cancer potentially against, theoretically, against people who have, yeah, maybe not.
And actually, in general, the fear is too high, and therefore, it's easy to here's the shot from optimal arousal for every case.
Yeah.
And if people are too high, they also know or people are so scared about getting diagnosed.
So even though you might think that a lot of the other things might be aligned, for example, we are in a prepaid healthcare environment. So we set up our systems kind of largely around like population management. That's very different though than potentially here where there actually are alignments like, oh, you get paid for every CAT scan. You get paid for every bronch. You get paid, so there actually might be aligned systems, which can be a good thing, for actually prompting healthcare systems to put things into place. And yet, there are these other ones. So, there's a whole bunch of these. And so, I'm just going to kind of go over around some ideas of kind of like systems that might help to be able to evaluate some of these. Defining some of these parts, some sample ideas, and some support mechanisms. So one thing is that this is a little different, this whole area, than the concept of epidemiology. Epidemiology, I think of as a little bit more of the why. So you might ask a question that there's no intervention for. And implementation, which is the how. We already know we should do this. There's been 10 randomized trials, but we just aren't doing it. Lung cancer might be one example of that, although there might be questions. So this has a little bit more in the way of questions in it. So part of this was we had to come up with this concept of like, well, what's an impactful idea? People said, okay, well, I'll talk about the funding mechanisms in a minute. But so, with a whole bunch of different people, we kind of came up, researchers and leaders and funders, like, well, if we're going to say this is like what we're funding, what would it be? And I actually have found this tremendously helpful for our NIH grants and tremendously helpful for a bunch of different things because it actually kind of got everybody on one page. And, first of all, it's like a priority. it actually addresses some meaningful clinical outcome, healthcare value, or some patient provider experience. There's a lot of ideas that actually don't even fit into that. The second thing is that there's actually some clear evidence or implementation gap. So you're not just kind of like replicating like the 5th iteration of something, or there's been 3 randomized trials. If that's the case, you might just be ready for implementation, but there's actually a gap that you can elicit. The third is that there's some clear planned action. Oh, that goes back to the other slide. If we know this, then we're going to do that. And you can outline what that is, and that's something effective. And the last thing is that there's specialty, priority, and operational readiness. So this gets to be a little bit more the case for the embedded research world. Maybe regular research, you don't always have to worry about this, but that if you come up with an answer, your colleagues say, yes, we actually are going to do this. And this was a problem with some of the early projects which were approved kind of before we came up with this concept, was it would go through the whole cycle and then it would get to the end and people would say, well, we're not going to do that, you know. And so by bringing those people in early and having part of that team, like, oh, they were the deciders, the person who's actually in charge of radiology. If there's a radiology project on the clinical side, it's like, oh, okay, they're involved in kind of forming the project. So I mean, there's all sorts of steps from ideas to prioritize, to analyze, to implement. And so you kind of have to come up with mechanisms kind of like to deal with each of these. And some of those require funding. So, I mean, I guess one question is like beyond federal funding and the long required timelines, it'd be interesting to learn from you all, like what are the rapid cycle mechanisms, internal mechanisms that are used here to be able to fund projects? So that's different than people, but like projects. Could anyone share like kind of like what are the, for your mechanisms or the projects that you've done? Are there mechanisms here? Yes. And where does that project funding come from? You said from Medicaid. So do you apply to like a state fund for that? It rolls up somehow. And what scale is that? Like what kind of, if it's like a project proposal grant or something? So theoretically, it could be even into the millions of dollars. Okay. Others? Well, that sounds awesome.
Doug, I can
Yeah.
comment. So we're talking about projects, but I think career development is also an important aspect here. And the Department of Medicine has an outstanding early scholars program that really funds, junior faculty members to really launch their research, get the protected time that they need to apply for.
Great. Great. So this is kind of like an early scholar program that's like it's for supporting the people. Other project specific mechanisms?
Yeah, the department and the hospital also for value small grants.
Great.
Yeah, that something gets the data.
So kind of the hospital or organization kind of providing kind of like some specific project grants. So, so I'm going to go over just kind of like some sample, like, well, I know that this has been kind of conceptual so far, like what are these types of projects that you're talking about? I'm going to give some examples and then actually a couple of the specific support mechanisms that went behind those examples. So these are kind of like in a few different areas. Like, one is like being able to improve population health outcomes. Like you have an intervention, you're trying to be able to maximize the impact on it or get it to the people who need it. Really kind of transforming care. Like, oh, well, we do it this way. An example of transforming care might be saying, we're no longer going to be doing cabbages. We're actually going to be, we're transforming care really to more of like a percutaneous interventions for cardiovascular disease, or more recently, like what we had done over like for TAVRs, like for example, for aortic valve disease, where like that's like a whole system redesign, like, where you're going from big open heart surgery to something else. Or can you leverage big data for making decision-making, kind of optimizing benefit and value? So there's this little battery, if you remember that, that's like kind of population, kind of like energizing things, transforming care, kind of like really changing the system, and then just kind of trying to be able to target things better. So this is kind of one of the battery ones, which, can we use AI to identify who is most at risk of future breast cancer after a normal mammogram? So what we did was we were able to look essentially looked at large number of mammograms and looked at all the people who after a normal mammogram developed breast cancer, and then applied a bunch of different AI algorithms actually to the original mammogram that had been read as normal. And then so you had to kind of do all of that, right? You know, that's getting the images, kind of doing all the different things. And then like looked at how well that predicted. So, and then the second part, well, I'll just stop there. If someone was designing this as an NIH grant, between like when you started applying to when you were kind of like getting the answer to like how well this predictive approach would work, how long do you think that would take? Okay, that's probably 7 years. I mean, you know, probably just a year's worth of grant applying, right? Okay. This was able to identify, depending upon which algorithm you use, 25 to 50% of the women who had a future cancer were identified from their baseline normal mammogram. That then led to, a pilot of outreach for high-risk women. So in other words, like you have a high-risk one, let's make sure that you get your mammogram next year, you know, like really kind of prioritizing that they actually are having active and ongoing screening. And also started to pilot AI flagging of high-risk women in real time. So like that if something was read as kind of like normal, that the radiologist would say, hey, you know, this is one you should really be taking kind of like an extra look at. This project from start to finish was about 14 months. And right now these pilots, and this is actually being done in the form of like a randomized trial. And so again, this mainly because it was able to have all of these different components where we were able to work directly with the IT people, directly with the radiologists, you know, et cetera, et cetera. So, but it's really impressive sometimes, and just huge credit to Vignesh Arasu. But he's also a radiologist who went and got his PhD, and he applied for an NIH grant too. But part of it is that he had about, I'll talk about it in a minute, he's a member of our physician researcher program that has about 20 to 40% of their time protected for research. And that enabled him to kind of like accelerate and get this project going, as well as develop external mechanisms for funding. So this was kind of like a similar one, but this is a health system redesign. So most women who are having uncomplicated mastectomies were having them done on an inpatient basis. They would stay in the hospital for a day or two, and then they were gonna go home. Lots of things have been changed from kind of outpatient to inpatient. There's a question of like, sorry, inpatient to outpatient. Is this actually really needed for kind of relatively uncomplicated surgery? And so a redesign was done, and then we were actually kind of called in to evaluate it after it was underway. And so it went from within, this is like 2017 to 2019, within about a 14-month period of time, it went from 30% to 80% of the mastectomies are actually being done as an outpatient. Now, interestingly, this was right before the pandemic that this was done and this was published. And this became hugely important for that context because then no one wanted to be in the hospital, but you had to have your cancer taken care of. And so everyone was like, at first, I think people were kind of like saying, I can't believe you were sending people home on the same day. And that changed about a year later to like, can you tell us how you operationally made it happen that people were going home on the same day? But then there's other parts of it. It's like, are people coming back to care? Are people having to come back to the emergency room? Are people having problems? And the answer was no. There was actually no difference in kind of like returns to care. So, you know, this is like relatively high value. There also, but there were some differences that were seen between high and low volume surgeons. And there are also some difference in demographics. There was African-American women were actually more likely to return to care. And this was identified kind of like through this analysis, but it wasn't really identified if it had just been kind of like a regular operational project. There was an intervention that was done around that in terms of being able to contact people, education, and in a follow-up analysis, this number had actually gone up to 91%, and there were no longer any differences by comorbidities or demographics or surgeon volume. The last thing is for folks that hepatitis C treatment is kind of not as big of an issue right now, but you know, a couple of years ago we were rolling this out really like for everyone, and for some unclear reason, African Americans were seeming to not respond as well. Like maybe and needed 12 weeks of treatment instead of 8 weeks of treatment. You know, kind of biologically, this didn't really make sense, but people were saying, well, we don't know. Maybe it's just something different is kind of happening. So what we evaluated, given we had a very rigorous program in terms of contacting people, making sure they were taking the medications, et cetera, is this actually really true? And it turned out that actually within this program of a large number of people, over 2,600 people, there was actually no difference like between these groups. Well, what does that actually mean? You know, it means that an integrated navigated approach can actually close disparities. It's easier for patients to take it for 8 weeks than 12. There's fewer side effects. From the health system side, there was less need for MAs, less need for monitoring, less need for all of these other things. The drug cost was about $30,000 to $50,000. This came down to about $1 million per 100 people treated. So when people kind of talk about these types of projects and supporting embedded researchers as a cost, as opposed to an investment, there's tons of these examples we can give. This alone, the funding mechanisms I'm about to describe, this alone, this one project paid for every single one of the funding mechanisms for years, and on an ongoing basis. And each of these things, actually, the adenoma detection thing alone also, paid for essentially the entire program every single year, even if you never did another effective project. So there's all sorts of arguments kind of like for why this is kind of like a good idea. So the last one is just immunomodulators. So as you, like way back in 2020, when COVID first came out, everyone who was on any type of biologic or immune acting agent was very afraid that they were more likely to get COVID. And if they got it, well, they were immunosuppressed, so they were just gonna die. And so people were kind of stopping their medicines, or, should I take it every other day, or something else. So because there was this mechanism, again, imagine if you had to apply for funding to answer this question, like how long would that take? Instead, because of one of the mechanisms we have, it's called a rapid analytics unit, we were able to evaluate this by the summer of 2020. So, and found that, there basically was like no difference for the oral immunomodulators. There was for prednisone. That's probably just because people were sicker, because we later found out that prednisone actually is probably good for people who have severe disease. And among all of these different agents. So this was kind of like rapidly disseminated. We created dot phrases within Epic, so that you could kind of like inform patients who had this question. And essentially just like within months of the pandemic starting, because we have such a large population, we were able to evaluate this and kind of like disseminate that information. Huge credit to Fernando Vallejos, who's actually our IBD lead and the head of GI at one of our centers, who also kind of like had led that. So the support mechanisms, I'll just go through this relatively quickly. I'll kind of, you actually answered this to some extent. I was curious like what your internal mechanisms were for supporting people as well as projects, because that's just so key. And I think that was one of our concepts, was like, if people don't have a sustained career, like if all you're gonna do is like, we're gonna give you $60,000 to do this one project, how does that person create a sustained career as an embedded researcher? You really need to be able to have some kind of trajectory. And that's one of the reasons why people go for external funding, because you get a 5-year grant, but then you actually have to have a project that is going to be lasting for 5 years. So it gets to be this very kind of complex thing. So, this is kind of the website for, which kind of pulls together a lot of stuff that we are doing. It is called the Delivery Science Applied Research Program, but there's a number of different kind of funding mechanisms. It enables a lot to be done. Over a 2-year period, we did about 80 projects, across these different mechanisms, just looking at a whole bunch of different things. Standardized ovarian risk stratification system. Like people were coming back with like cysts, and one of the choosing wisely initiatives is like, don't follow up an incidental ovarian cyst, low risk cyst. Okay, the problem was like everyone was still getting ultrasounds because like, oh, there's this cyst. It's like, and there's no definition of what a low risk cyst was. So kind of fairly rapidly, one of our GYN oncologists, kind of using retrospective data, put together a definition of a low risk cyst, tested that prospectively, and then that was actually integrated into all the radiology reports along with recommendations. This does not need follow-up because there's basically zero risk of cancer. This should have a follow-up in 6 months, et cetera. For our, I don't know if it was our pulmonologist who in the back up with the lung cancer, kind of like a similar thing around structured lung cancer reporting, electronic algorithm predicting deteriorating glycemic control, kind of to be able to know who to intervene on. And these cover so many areas, but it's mainly because it's the people who are in the specialties know what the problems are. It's not about like a half a dozen top-down projects. It's about how do you put together mechanisms that support, like hundreds of projects and people, kind of like over a long period of time, because there are so many impactful questions. So it's also putting together training and support mechanisms for people, kind of mechanisms for collaboration, how do they get started, et cetera, et cetera. There's a bunch of different funding mechanisms. Some of them are really short, like so that, for example, that targeted analysis program, that was that 6-month one. That was the one which kind of funded that COVID analysis that I had mentioned. There's the rapid analytics unit, a little bit more in depth, like 12 months. Delivery science grants, these are about the size of an R21. It's about $275,000 over 2 years. There's a physician researcher program. Currently, we have about 13 people in this. And that's the one that's like 20 to 40% time plus about $125,000 a year to be able to execute projects. I kind of liken this almost like it as an endowed chair. So if you think about like and it's a 4-year renewable, so it's in 4-year blocks. And essentially they're doing a series of 2-year projects. But the amount of money each person's personal salary support is actually, and project support is larger than the largest endowed chair like money going off of that I've been able to find. But this was invested because of the reasons that we were talking about, that they're working on projects that the people who are the leaders are interested in. And so that kind of totally realigns that. The health plan also funds Kaiser Foundation Health through their community benefit program, like about another 30 grants per year. These are about $70,000 to $80,000, but we actually have linked with them so that there's like one common application method kind of across all of these. So the last part is kind of developing communities and resources. So we were actually talking earlier about like how people just kind of can kind of be isolated. We were talking about kind of like when there was you might have someone who's interested in something, but they're like not connected to the 30 other people in the medical center who are interested in that because you're like in different specialties. Our setting actually even has less connection within the specialty because we're across all of these medical centers. So if you have like one person who's a pulmonologist and they're interested in something and they're at this medical center, maybe they're the only person who kind of does research, and none of the other people, you might have one person at each medical center. So you might have 22 pulmonologists doing research in a pulmonary group that overall is one of the largest pulmonary groups in the United States, but none of them know each other. So one of the things that we had done also within the last 3 years is kind of develop what are these called these specialty research networks, just to be able to connect people better. We survey people. We do this is just through centralized infrastructure support, set up meetings, putting together, disseminating the work, and pretty soon, everyone kind of knows like, oh, well, these are the other people, these are the other projects that are going on, and it kind of has accelerated kind of setting up collaborations and including kind of cross collaborations. And then the last bit, sorry, I went twice. The last bit, is being able to kind of support investigator development with kind of time, finances, and recognition. And we put together a bunch of different mechanisms. This is like that physician researcher program I mentioned. But part of that is like twice a month for a half a day, all 13 of those people actually get together and share what they're doing. So again, I'm working with this IT person. Whoa, I didn't even know that IT department existed. Everyone's probably had that experience. But this allows essentially acceleration of things kind of like across specialties to be able to have shared learning. These are just some of the folks who are involved with this, and they extend from people who are in behavioral health, infectious disease, really kind of almost every single surgical subspecialties. The last is like for dissemination and implementation. I love this slide, I asked around and nobody heard anything. And, this is like a classic thing of like, you publish something, you spend years of your life, and then like what happens with it kind of like at that point. And that can happen with these projects too. And it's really this last part where, you've done all this, but then kind of what happens here. So all of these things that we've talked about have helped to be able to connect people to making a rapid cycle change so that when the idea is there, the leaders who are in the specialty know about it as the results are coming out. But one of the parts is like, well, how can you really maximize that? So do we have any dissemination implementation experts here? Is there anyone involved in D&I? Okay. The interesting thing about, I'm sorry, were you raising your hand?
I don't get it out my next.
Yeah, I don't even experts involved with.
I coordinated.
Have read a paper about.
I'm coordinating an implementation project in the Netherlands, so together with 4 national expert centers there below.
Great. Which center?
Well, 15 centers, technical surgery centers in the Netherlands.
Great. So like Erasmus and kind of like all of them. Yeah, actually, I'm friends with Kuipers, actually, who's a gastroenterologist who now is actually your Minister of Health. And so we kind of like talk about the things in the Netherlands quite a lot. And I've collaborated with like the Erasmus group on modeling and stuff. It's a tremendous group. So that's super interesting. So you kind of like, and actually the Netherlands is like amazing about this because they build a lot of this stuff in, they're thinking about, when something is starting, they're thinking about the end game of like how many people we're needing. They're creating modeling to be able to do this. So, I mean, I have learned a tremendous amount from that. And you could all learn a tremendous amount from this gentleman. But in that, so there are these different frameworks. And the interesting thing is like, what you would think would be a very pragmatic thing, dissemination implementation, because of the funding streams, has turned into kind of like another academic discipline, which oftentimes is a little bit ivory towerish. And I don't mean that in any negative way. I mean, it's like ivory tower in some way means like really rigorously looking at the problem, but it's actually not as connected. And delivery science is kind of the same. And so there are these consolidated framework for implementation, and there's there are a number of these things that have pulled together all sorts of different ones. And so we started off with this saying, well, how can we make this better? And so we did like a systematic review. We looked at all of these different things, we kind of like pulled them together, and then we tried to model them. And we said, all right, well, let's just kind of pull together. And we ended up creating, all right, well, this is like what this framework suggests, and this is like the expert framework. Okay, we have to sit down with a healthcare plan leader and go through 10 pages of stuff. Like, well, that actually no one was really keen on that. So we we cut it down to, all right, well, what would this look like with just like some key aspects from 3 to 5 pages? Tested it out on a bunch of projects. This is unacceptable. We just can't get this done. And so the ironic thing was so then we ended up reducing it to like a single page, and we submitted it for publication. And so that's this kind of just came out a couple months ago, but it's the implementation checklist, which is a pragmatic instrument for accelerating these cycles, where you're kind of building it in at the beginning of the discussions. And the ironic thing that we put into the introduction of this paper was, the ironic thing is that implementation frameworks are not being implemented. And, which was completely the case because they're just too ponderous. And so no one in a rapid cycle healthcare system is going to be filling these things out. And so, this is just kind of one example, of how you can start the discussions, just kind of being able to say, who's going to be involved, who should we cut, who should we talk with, so that you can at least get that kind of information kind of like on the table. So, we kind of started off with like, why you go into medicine, how does this impact us here? And, I'd just say, this is a time of change. There's always interesting new career paths. There's aligning goals between patients, provider, health systems, and developing new funding mechanisms. And kind of getting back to that, it's really not a matter of, how we can afford to build these infrastructures, but in this day and time, kind of like how we can afford, not to. And I think we were fortunate in being able to convince our board and kind of like all the other things to be able to put together these support mechanisms, because we're able to align a lot of these different areas. And talking with a couple of people, even like one of those areas is around physician wellness and burnout, for which there's a committee. And that committee was influential for the board of, these are providing another pathway and support for people that I had not anticipated originally, but it's like, wow. And that there are different ways of being able to kind of like influence and kind of be able to change and develop new mechanisms. And it really is across like all of those areas that you were talking about and that we were talking about. And it can change like both those single interactions as well as kind of like the meta level interactions. So, thanks so much. I think many similar concepts exist across specialties. Your group is going to have great ideas that can change care, and it's, helping to be able to put in kind of some of these mechanisms and developing new pathways. These are just some of the folks I work with and kind of like our core, and just, reflective of, again, probably like a couple of hundred physicians across the delivery science applied research effort who are doing all of these projects. Thank you so much.
Any questions for Dr. Corley? I'll start with the first one while we're waiting. Just if you could drill that on one of the last points you talked about, which is getting those above, the board, whoever, to support these efforts. Do you end up having to explain all of these projects, including, say, wellness or education, in terms of ROI? Or are you able to put them into this broader thing of improving the organization and get funding in that sense? Or how dollar for dollar does it get?
There were kind of like two steps. I mean, I think the first step was the physician researcher program, which was one of the biggest investments and which kind of went by in stages. But I think when we made that was a board presentation. And when we made that presentation, I mean, everyone's interested in return on investment in some way, shape, or form. it depends upon what you view as a return. Like the physician wellness people, their return on their investment is like, you're providing more career paths and other ways because people are saying, I'd like to do something else than, do medicine kind of like all day, every day. But we presented 3 cases of a little along the lines of, people think this is a cost, but it's actually an investment. Where like, if we just knew the answer to these 3 questions, any one of these 3 questions, and we could get this answer within 1 year, and we think the answer is probably going to be this, but we can't do that because we don't have the answer, it would pay for like this entire program every single year going forward. And so I think that was kind of somewhat compelling. I think it was that, along with there was this big movement towards providing other opportunities for physicians and how do we support people better, helps with recruitment, helps with kind of like all of these different domains. Because the recruitment people want more, there's just all of these different domains, and you kind of like can kind of like have that kind of be like one package. And then the extensions were basically more or less kind of an extension of that logic, but then kind of showing like, hey, look what we've done in the last 2 years. It's kind of like the Dr. Seuss thing. Oh, where can we go?
All right, so I got a question. Doug, thanks for that great talk. I guess one question, there's sort of, maybe it's 2 questions that are related, and kind of a follow-up to Jeff's question, which is Kaiser's an integrated system, and there is a different return on investment that they might see for some of these projects compared to a health system that maybe still is built on a fee-for-service, which you alluded to earlier. And I wonder, both how we can convince a health system that is still based on mostly a fee-for-service to do that, or do we need some external force, so to speak, a governmental regulation or whatever, to help spur that along in a way that would reduce cost and improve outcomes and access?
Yeah, so great point. There's I'm trying to remember the 3 components. Someone said like, to do change, you kind of need a few things. You need like a good idea, you need like an advocate, and you need some heat. And and so kind of like, where does the heat come from? And that heat might be financial or others. But let me just give one example from your colleague who had the lung cancer screening question, or the lung cancer screening comment. So like that's like a perfect example of knowing what people's there's different incentives, but they may be the same. Like your incentive may be to increase lung cancer screening, but if you actually put that into the framework of like, look, if we set up this navigation system that's going to involve some investment from the healthcare system, there's going to be an MA, there's going to be this or that, there's going to be this outreach. But you know what? That's going to result in this number of more CT scans, these people coming in and having, like surgery, these people coming in and having chemotherapy, like the cost of this, it's, and I think a great example of this is actually has been realized on the financial aspect in GI, but it took a long time to go through. Like when I was starting faculty, hepatologists were actually very complex specialty because you're looking at like very sick patients. But they were essentially compensated similarly to the average office-based person because that's what they were doing. They were seeing people in the office. And it was really hard for them to actually earn their income because they were spending way more time because they'd be having to spend a whole hour on someone with liver failure and blah, 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 blah. But none of the things with liver transplant could happen without the hepatologist. And as there started to be difficulty in recruiting hepatologists, then there started being like other parts of the system then started saying, hey, we'll help pay for your hepatologist. And so it helped with recruitment. It kind of like changed their salary structure. They started getting more support with nurse practitioners. But this is all the same thing. Like, if for the lung cancer realm, like the surgeons, the chemotherapy, and so that I would actually view that as being like a relatively simple argument to make around this. If you're saying we want to do a project, now that's obviously very operational, but you could even just do a research project of saying like we don't know how many people there are who are unscreened. If we knew how many people there were unscreened, what their demographics were, who these target groups were, we could implement a screening program. It's like that if then, and so that's where it's somewhat where the disparities, where the problems. That actually is a research topic and publishable, but it also informs this other one. And I can think of 100 of these for for-profit ones, for for-profit institutions. Again, it's just a matter of aligning. There's lots of ways to be able to align things.
We have 1 minute left. If you could just talk, Dr. Chopra and I were sort of whispering about this. how is your IT infrastructure set up to do this kind of embedded research? It sounds like there's a fair bit of support. What does that look like across the institutions?
So the Division of Research is a freestanding group. So it's not within, so it's all these different specialties, but it is a freestanding group. So it is not, for example, the IT for a GI project person is not resting within the GI division. So there's actually, that actually is helpful in itself. Although I think there's different ways of structuring that. But also then, what we did ultimately when we were putting together some of the things, like the Rapid Analytics Unit is about 10 people. It's about 5 analysts and about 5 investigators. But in terms of careers, and some of them are up here, some of the investigators, they spend 20 to 30% of their time working with a clinician, pairing with a clinician to do the Rapid Analytics Unit project with one of the analysts. The analysts are based within the Division of Research, so they have their own community of analysts to be able to help, to be able to work with. But that's kind of like more or less how it's structured. But I think, again, like so many of these overlapping things are just so helpful that our researchers, they love it. They're like, oh, I'm working with a clinician on this clinically active thing. How cool is that? And they see like a rapid turnaround result. So they actually love, and they like the hard funding too, of like 30% of their time is like, being covered or something. But there's just like so many synergies that are with it. But part of it is with the ITs, it is kind of like in a centralized group. And that enabled us to rapidly build out an IT infrastructure for AI projects, and for other things too. But I would say that AI breast cancer one, that AI project was actually done within the operational infrastructure of the organization of KP, the people who do Health Connect and everything else, just because a case was made for it. It's like, we really think this would be pretty interesting to do. And they're like, wow, that was really cool. So.
Great. I think we're out of time. So
All right,
Dr.
great.
Corley, thank you very much.
Thanks so much.